So this one is about cervical radiofrequency neurotomy techniques. Again, is mostly an anatomy type of talk, so there is not, hopefully, much controversy like there may be with indications or results for spinal cord stimulation. Yes, there is controversy. Here, you need to identify your patients appropriately, and you need to choose who you want to fight a battle for and with. Because sometimes you may have patients that have had a strong response to a set of medial branch nerve blocks, and all of a sudden you do an ablative procedure, and they come back and they tell you that the 75 or 100% pain relief that they have with the medial branch nerve blocks is not there anymore. So you really need to pick your patients well. Anyway, again, I have still nothing to disclose over here. The information on the guidelines from the SIS, from the Spine Interventional Society, guide a lot of the things that I'm saying to you today. A little bit of the anatomy of the medial branch nerves of the for the cervical facet joints. As we said before, the medial branch of the cervical dorsal rami curve around anterolateral, lateral, and posterolateral aspect of the ipsilateral articular pillar. As you can see, both in this lateral view cartoon and in this AP view cartoon. These are the location for C3, 4, 5, 6, and 7 medial branch nerves. What is the trajectory of the needle? The appropriate placement of the needle for both medial branch nerve and radiofrequency ablative procedure of cervical medial branch nerve blocks aims at the lateral aspect of the articular pillar, as you can see in both these cartoons. You should try to place the needle as close as possible parallel to the plane of the joint, as you can see in the C cartoon. And the pillar view on the D cartoon shows the waist of the articular pillar right here, and shows how the needle, which is represented by the black dot, lies parallel to the nerve, which is labeled as N. You can try to enter this to reach the waist of the articular pillar in two possible ways, either inserting the needle along a sagittal path in order to reach the lateral surface of the pillar, as indicated by the red arrow, or you can try to insert the needle using an oblique path, which is usually 25 to 30 degrees oblique from the needle placement for the sagittal path, in order to reach, again, the anterolateral surface of the articular pillar, as indicated by the blue arrow. For medial branch nerve ablation between C3 and C6, here the cartoon on the left shows a lateral view of an oblique path, the way it looks on lateral view after needle placements, and the way it looks on AP view after needle placement. And this is the way it would look if you choose a sagittal path, a lateral view, and AP view. I remind you, this is the sagittal path, and this is the oblique path. I don't have any particular preference for either. I've been taught that usually you need to start at least some degree away from the path that you would choose for a sagittal path. However, interestingly enough, I was always taught that the best possible needle placement is this one over here on a lateral view. So, and we'll discuss this when we are working on the cadaver. It depends on how you want to position your C-arm with the patient in the prone position in order to identify the needle entry point. And there are people who start with an AP view and then go to ipsilateral oblique tilt and then caudal tilt. And there are providers that immediately start with a lateral view and try to enter the needle directly, to place the needle directly the way that this image on a sagittal pad shows it to be. And this study done by in Switzerland in 2014 on the lateral view, the area that are located into the dash parallelograms right over here are the areas where it would be appropriate and correct to place a needle for a procedure performed at the C3, C6 medial branch nerve block. As you can see, the needle tips located in the dash triangle over here would be what it would be appropriate for a performing procedure at the C7 medial branch nerve block. These are radiographs for of needle placement for the C3, C6 medial branch nerve blocks that they have been, these needles have been placed using an oblique pass. Again, I remind you the oblique pass is this one over here. And you can see the way that the tip of the needle lies behind the posterior margin of the foramen at that particular level. And the circle over here in the second image indicates the location of the needle for a second burning lesion at that particular level. These are needle placement that have been placed through a sagittal pass at the C5 articular pillar level. You can see the arrow on the left image that indicates the location for a second lesion at that particular level, and the dot on the picture on the right indicates the lesion, the needle placement for another lesion at that particular level. As you can see, the final needle placement is into the waist of the articular pillar at the C5 vertebral level. You have already seen this cartoon. These are sketches that indicate the placement of the electrodes for the C7 medial branch radiofrequency ablation. In the sketch B, you see that the electrodes lie against the lateral surface of the superior articular process and across the top of the transverse process of the C7 vertebra. These are images that shows the position of an electrode in the correct place, in the correct position for a C7 medial branch radiofrequency ablation. You can see on the image number A that the electrode has been inserted through a sagittal pass across the lateral aspect of the C7 superior articular process, which lies right over here. And the circle indicates the areas where you can position the probe for the further lesions of the C7 medial branch nerve block, medial branch nerve, excuse me. The lateral view on the right side indicates the position of the electrodes lie across the lateral aspect of the C7 superior articular process, which is right around there. For the third occipital nerve block, basically these are sketches of the way that the electrodes would look if for consecutive placement and for consecutive ablation of the third occipital nerve block. These are lateral views of an oblique pass. This is the lateral view of a sagittal pass. This is the AP view of an oblique pass, and these are the AP view of a sagittal pass. These are pictures that shows third occipital nerve RFA performed using an oblique trajectory. We have A, B, and C are lateral views, and and D, E, and F that are, there is a typo over here, I apologize, and D, E, and F that are AP views, and you can see on the top three images an electrode in the high position, in the mid position, and in the lower position. And you do not necessarily have to do lesion at all those three levels. My recommendation is for you, however, to do that, because it is likely that if you do more than one lesion, you are able to disable the ability of that particular nerve to conduct the painful stimuli, and you have a qualitatively better ablation that is going to last a much longer period of time. The same image, you can see the same images on the AP view, high position, mid position, and lower position. This using an oblique trajectory. These are instead the same pictures taken using a parasagittal trajectory. We have, again, high position, mid position, and low position on a lateral view and on an AP view. There is an increasing interest into performing this procedure with ultrasound guidance. I have to admit I have not done any of this under ultrasound guidance. I did not grow up in my training in performing this procedure under ultrasound guidance. So I show you what I found in reviewing some of the literature. This was published in 2014, and they seem to conclude that the ultrasound may be an accurate technique to perform cervical facet nerve blocks in volunteers, except for the medial branch blocks of C7. Here you identified with the arrow the bony targets for cervical and medial branch nerve blocks, which is what they label as the groove between two facet joints. And the groove obviously is kind of right over there. Also, they state that one reason for the low success rate for this block, particularly the C7 medial branch nerve blocks, may be the difficulty in scanning the distal cervical vertebra, because the clavicle is there and may render the placement of the transducer a little bit more complicated. Another additional problem is that the target is located slightly deeper under the skin than our other targets, which may to some degree decrease the visibility of the target itself. Yes, yes. I mean, you don't see the needle, but it looks as if you see the dot over there, and I would imagine that the needle would come out of plane over here rather than this way. In 2012, there was another article published before the one that just showed you, and this is coming in plane, I would imagine, and shows what the targets are for the placement of the needle at the C4 medial branch nerve level. And you can see the needle that has been in position after the local anesthetic has been injected. So this is the local anesthetic right over here. And you can see the needle obviously end right over there. You can see the local anesthetic right over here. You can see the lamina that is right around here. And the articular pillar, which is right over here, and the posterior tubercle of the transverse process or transverse process that is somewhere around here. And they say, hey, you know, this is really reliable for third occipital nerve blocks and for medial branch nerve blocks between C3 and C6. However, they need further study to evaluate and to validate the efficacy of this technique. Some study came in 2014, as we have seen, and it's not easy to, as they say, to identify C7 for the reason that we have identified over here. Interestingly enough, the article that was published in 2014 came up with an editorial by Ratmel and Boeven-Hendren, in which they say that painful facet arthropathy often accompanied by formation of large bony osteophytes that distort the usual anatomy. So in obese patients, this success rate may be significantly low, demonstrating that in real clinical situation, the utility of using ultrasound may be somewhat limited. Also, they were commenting on how vascular uptake for this procedure may be relatively common, with an incidence that range between 3.9 and 7%. So, and potentially lead to what they say catastrophic complications. They also were commenting on the ability of the ultrasound to be sensitive enough to detect needle penetration in these small vessels. So the ability to detect potential vascular uptake may be a little bit problematic. Also, that's it, so sorry. A little bit of physics about monopolar versus RFA versus cooled RFA. Usually, the volume of tissue that is coagulated assumes an elliptical shape in longitudinal section and a circular shape in transverse section, as you can see in this cartoon. Usually, the recommended temperature for a regular RFA, monopolar RFA, is 80 to 90 degrees for a period of time that may oscillate between 90 seconds and 120 seconds. There is enough evidence to show that after 90 seconds, the further growth of is limited because the coagulated tissue may have an high resistance to the flow of the current. In contrast to the monopolar RFA, or quote-unquote traditional RFA, the cooled RFA uses the ability of the cooling to keep the impedance low around the electrode by cooling it. So the low impedance means lower resistance that allows the alternating current to eat tissue for a longer period of time, allowing the electrode to coagulate larger volumes of tissue. Usually, the recommended temperature for cooled RFA is between 45 to 50 degrees Celsius for many minutes. Cooling is usually achieved by having water passing through a channel which is incorporated into the electrode. Usually, cooled RFA lesion seems to be extend more distally than the similar lesions that are performed with the use of monopolar electrodes. What usually RFA, what are the mechanism by which RFA causes pain relief? They usually, as we said, coagulate the proteins in situ and do not breach and do not kill, do not disrupt the nerve per se. And usually the recovery from an RFA ablation requires the presence of intact endocellular mechanism that allow to clear the coagulated proteins inside the axons. The pain relief persists as long as the nerve is coagulated. And once the nerve is repaired, the nerve recovers the ability to conduct and to resume, and pain can eventually recur. All efforts should be made to maximize the length of the nerve coagulated, and that's the reason why I'm telling you that more than one lesion is usually the best possible way to handle patients in these conditions, with these conditions. What are the hazards? Usually you have to be aware about the possibility of injury to the spinal cord if the electrodes are placed too medial to the joints inside or inside the vertebral canal, obviously. Injury to the spinal nerves and vertebral artery if the electrodes are placed too far ventrally or anterior to the target zones for cervical medial branch. Usually, if you are at this posterior dorsal to the vertebral foramen, you are in appropriate position, in correct position, and that's where, stimulation, sensory and motor is enables you to understand whether or not you are too close to the spinal nerve. Repeated denervation of the cervical musculature can be a problem, the multifidus muscle in particular. So I would probably try not to block more or to kill, so to speak, or to ablate not more than 3 nerves at a time. And this is a very well known side effects and complication of third occipital neurotomy is the development of ataxia. Is not that frequent. I believe happens in 3-4% of cases. It's 3-4% is a big enough percentage to me in order to always want to treat one side first and see how the patient is doing before considering treating the other side. And sometimes patients are not exactly clear as to whether or not one side is worse than the other. They have the tendency to tell you that bilateral is their problem, and then you end up doing one side, which is the side that they may tell you is a little bit more bothersome to them, and they are okay, and they don't need anything else done. That's it.